Hello, my name is Jorge Castillo. I'm the clinical director of the Waldenström's Macroglobulinemia program at the Dana-Farber Cancer Institute here in Boston. And I'm here with Dr. Ramon Garcia-Sanz from the Universidad de Salamanca in Spain. And today we're going to be touching base in some of the interesting concepts that we are reviewing today at the International Myeloma Workshop here in Boston with regards to Waldenström's macroglobulinemia. I think we're going to be talking about the frontline treatments with patients with Waldenström's. Then we'll talk a little bit about the relapse and refractory options in these patients, and we'll talk about the exciting clinical trials that are currently available in the United States and in Europe for this disease. So to start, would you like to say some words?
Maybe just to remember the initial management for the patient that will start with receiving a patient who has a monoclonal component of IgM type, maybe with some clinical symptoms, especially anemia, which is the most frequent symptom. And in this patient, we had to make several approaches for evaluating him or she in order to confirm the presence of a lymphoplasmacytic lymphoma in the bone marrow, which is the second criteria for diagnosing Waldenström's macroglobulinemia. In this workup, we also have to evaluate the presence of the MYD88 L265P mutation, which is present virtually in all patients. Any new series that we see has more frequently the MYD88 mutation.
I think that's an interesting point. So I think the diagnostic criteria have evolved a little bit over the last few years. I think having the bone marrow involvement and having the monoclonal IgM paraprotein and the MYD88 mutation kind of rounds, I would say in most cases, a very high likelihood that the patient that we have is a patient with Waldenström's macroglobulinemia. There's a second mutation that has been described in this gene called CXCR4, in which about a third of the patients with Waldenström's have this mutation. I don't think that has really caught up much in terms of in community practice. Do you guys check for CXCR4 mutations?
Yes, we are in an academic hospital, and we usually search for this mutation, but it sometimes is confounded with research studies that we are doing not only for these mutations but for other mutations that are much less frequent present in this disease. So it's not absolutely necessary, although it's highly recommended to search for this mutation.
Good. So I mean, I think we could potentially start talking about the frontline treatment of patients with Waldenström's. Just I think it's important to remember that some of the patients with this disease presents without symptoms. They are essentially asymptomatic. And the diagnosis of this disease is made incidentally for other reasons, because the patient had another blood work or another finding that prompted a specific workup for Waldenström's macroglobulinemia. In any case, patients who are asymptomatic should probably not be treated. We don't have any data that we prolong the survival of these patients or that we can actually cure these patients with our treatments. So the recommendation in general terms is to treat patients when they are symptomatic, and these symptoms are affecting the patient's quality of life, and these symptoms are actually related to the disease that we're treating. So the different combinations that we have available at this time, there are a number of different options. Fortunately, I would say, I think largely we can divide the treatment options in what we call chemoimmunotherapy, and there are a number of chemotherapeutic options in combination with rituximab. We do have the proteasome inhibitors also in combination with rituximab. And we have more recently the Bruton tyrosine kinase inhibitors, the BTK inhibitors, either alone or in combination with rituximab. How would you select the best treatment or the treatment that is more appropriate for a patient in the frontline setting in your practice?
In Europe, and more specifically in my country, in Spain, we have some restrictions about the reimbursement of these drugs. So for the first line therapy, we usually prefer chemoimmunotherapy, more intensive for younger patients, let's say bendamustine plus rituximab, or less or more gentle approaches such as CDR, cyclophosphamide, dexamethasone, and rituximab for elderly people. For instance, in an oral basis plus subcutaneous rituximab is very convenient for these patients. So in order to try to provide the longest remission duration for initial therapy, 5 years for Benda-R and 3 years or 4 years for CDR. So this is the first approach, although it is possible that in those patients who are not in whom we think that they are not capable to tolerate chemoimmunotherapy, we could start with BTK inhibitor, with ibrutinib. It's the approval at this moment. I think that in the United States it's a little bit different.
Yes, so I mean, we have some restrictions in terms of what we can provide to patients, but I think overall our guidelines tend to be a little less restrictive than the guidelines that you are mentioning. So we follow what we call the National Comprehensive Cancer Network guidelines, the NCCN guidelines. And in those guidelines, essentially any regimen that has prospectively shown that provides safety and efficacy can be included in those guidelines and therefore can be used for the treatment of patients with Waldenström's. So we find ourselves with more options in that specific context. So we can use bendamustine and rituximab and cyclophosphamide, dexamethasone, and rituximab. But we can also use bortezomib, dexamethasone, and rituximab, and also carfilzomib, dexamethasone, and rituximab. The last two are proteasome inhibitors. And also we can use ibrutinib either alone or in combination with rituximab in the frontline setting. So obviously there's a bit of a science, a bit of art in trying to define which treatment is better, since there's not a randomized study comparing any of these regimens against each other, essentially. So what we end up doing, at least in my practice, is I take a look at the patient himself or herself and look at her age or his age, look at the performance status, at the different other comorbidities that they have, maybe the symptoms that they are having. And we also look at the genomic profiling. I mean, we do have some data that supports some specific medications working better if you have the MYD88 mutation, like ibrutinib, for example, or the ibrutinib effect also affected by CXCR4 mutations as well. So we have all those issues into account. Now, reimbursement could potentially be an issue. Much more than anything else is the out-of-pocket expense from patients. Medications that are given injected or intravenously, at least in the United States, are almost covered 100%, while oral agents are covered up to some degree. And since these medications are not precisely cheap, then the expense out of pocket for these patients tends to be sometimes substantial. And that is, unfortunately, another factor that we need to take into account when we make decisions in the frontline setting. Having said that, I don't think there's one standard of care. I don't know if you agree with that statement, that there's not one precise standard of care for patients.
That's a problem in Waldenström's, because we don't have many patients, so the randomized trials are difficult. So we sometimes have to manage our patients with scanty data. So it's sometimes this is a problem. In addition to the what you have said about the problems that we have with the reimbursement, we sometimes provide the first line already thinking in the second line therapy, because sometimes it's easy to provide Benda-R or CDR thinking that in the second line, when the patient relapses, that is the rule in most patients, these patients can be treated in the second line with ibrutinib. In this case, there are no restrictions, and it's something that we can think about when we decided the first line therapy. So this is the usual way to think in our country at this moment. Because second line therapy, I would say that at this moment we can divide our patients in two main groups. One is those patients who relapse longer, beyond 4 or 5 years. These patients can be treated again with the same line as they were treated in the beginning. If the relapse is before this 4 or 5 years, we should change the approach, maybe to go for the ibrutinib, if the patient was treated with chemoimmunotherapy as first line, or we can change a soft chemoimmunotherapy for a more intensive chemoimmunotherapy, or if the patient received ibrutinib in the first line, this patient is candidate, of course, for chemoimmunotherapy, in which chemoimmunotherapy now can also use proteasome inhibitors. So this is the main approach in our country for the second-line therapy.
So essentially, the way it is approached here in the United States is, if you, for example, decide to have an alkylating agent, right, chemoimmunotherapy in the frontline setting, whenever you have a second-line treatment, you could either use a BTK inhibitor or a proteasome inhibitor in combination with rituximab. And if you choose one of them, let's say BTK inhibitors for the second line, then your third line is probably going to be a proteasome inhibitor. So essentially, we use those 3 different types of medications as a first, second, or third line, depending on where the patient is at that moment. Again, the factors associated with the patient's features and the patient's symptoms and all that also should play a role on the subsequent lines of treatment. So I think in kind of summarizing, I think the treatment approaches, I think there's value on personalizing the approach to patients up to some degree.